Good morning, and thank you, Dr. Yap, for the kind introduction. And I'd like to thank Paman Yanga for inviting me to give a talk on pediatric COVID-19 and vaccines. So the agenda for my talk will involve these four topics here: a bit of introduction on the background of the talk, some clinical manifestations, especially local clinical manifestations of pediatric COVID-19. How are we with the big kids and the way forward, and some take-home message. So everyone knows that it first started back in China in December, actually 2019, was preceded by a high seasonal influenza epidemic at that time. And I still remember that time we had an unusual high influenza cases at the time with a lot of complications from that stage before it was declared a disease of international concern and later a pandemic in March 2020. Our first pediatric patient actually came in January of 2020 that year on the first day of Chinese New Year. This is our first report on the first 4 cases from Hospital Sungai Buloh in that year itself, so that we can capture the gist of the patient's condition at the time. And a lot of data were missing at the time because it was a new disease. There was a lot of focus on what is happening in Wuhan, China, and we had a lot of help from the team that actually came from China to Malaysia. As you can see, the Greek alphabet is still a lot out there. We are at the moment at Omicron. We have been through the Delta and also the wild type original variants before this. So there's still a lot of variants that we can still use. And what makes the current variant Omicron interesting is that the mutations on it is almost 3 or 4 times more than what we saw in Delta. And that makes it very contagious, very infectious, but at the same time, it is not as deadly as Delta is. And we have been monitoring the genome manifestations of the virus, especially through CDC and also the European authorities. And as you can see, the spike in it actually became more prominent at the end of 2021, especially when it was first diagnosed in South Africa. And the proposed routes of COVID-19 transmission, I'm sure you know, we have gone through from droplets and contact, and then after that we went on to airborne and aerosolization. And in children particularly, we have found the RNA in the urine and feces, but whether it's viable or not, that's another matter. But it's something that is unique to the pediatric population. So your 3 point of entries are actually your mouth, ears, and your mouth, your eyes, and your nose. Now, what's so interesting about Omicron is that the incubation period is very short, about 2 to 4 days compared to Delta, which is about on average 4, and even compared to the original variant itself. So that makes the symptom onsets very early, and that means we're also very infectious early on. And hence, because of the infectious nature of the Omicron, that makes the use of rapid tests more pertinent compared to PCR tests, which actually takes more longer to come back. And also the guidelines have to change because of the shorter incubation period for Omicron, and also the isolation guidelines also have changed a lot due to the shorter incubation period of the virus. Now, when we first started with the wild type virus in 2020, you can see that the R0, or the basic reproduction number, which means the number of secondary cases that actually arises from the primary case in pandemic, where all the population is not vaccinated or immunized, is only about 2 to 2.5 here, as you can see. So it wasn't that contagious actually when it first started compared to tuberculosis, MERS, and even Ebola. But as it mutated along and progressed, you can find that R0 went up from 2.5 to 6.5 to 8 for Delta, and for Omicron, it's even reached the R0 of 15. That means it's so infectious that you can get almost 15 secondary cases from one primary sentinel case of Omicron. Now, so what are the clinical manifestations And before we talk about the clinical manifestations of the COVID in children, we also have to understand why initially when it first started, like say back in 2020, that the children was not actually targeted. A lot of speculations and even theories arise, and one of them actually more centered on the high ACE2 receptor expression, which is actually less in children, and hence the virus doesn't go to the lower respiratory tract as easily as the adults. And of course, at the same time, most of us also do understand that most children also have coronavirus infections when they are young, which are not the same variant as the COVID. Yeah? So these are basically normal coronavirus in the community, which actually infects children and has URTI manifestations even before the onset of COVID. So most children has this background, which actually makes them less susceptible to COVID-19 infection. We are now very familiar with this diagram here. Same like the dengue patients. For the COVID patients, we have a viral phase, and also we have a hyperinflammation phase. So this makes easy for everyone to, when we are treating COVID-19 patients, when do we start the antivirals and when do we start the anti-inflammatory therapy. And now, of course, you all know that the effects COVID is already in KKs and government hospitals, and hence, it makes treating COVID-19 patients, especially in adults, much easier. Okay, we know all about the clinical staging, and most patients, from 3 to 5 will definitely get admitted, even at this endemic stage. This is our second paper, which we published last year, International Journal of Infectious Disease. Again, this is reporting for the year 2020, the massive numbers of patients that was admitted to hospital Sungai Buloh for COVID-19 in children, and most of them, as you can see, relate along the upper airway, and also sometimes a bit of systemic complaints such as diarrhea and vomiting, but very little actually lower respiratory tract problems at the time. So hence, we were more than happy to allow the ICUs to be taken over by the adult population, and the pediatric population was actually not a significant proportion of it. But we do have now problems with the other more sinister portion of it, which is the MISC part of it, which we talk later. Now, and for Omicron, we found that, although it's not as deadly as Delta this year compared to Delta last year, then we found that, it actually coexists with a lot of other microorganisms. Especially, we have the studies have shown that it coexists with mycoplasma infection, influenza A and B, RSV, especially now when you have RSV season, So it's a very friendly virus that coexists in symbiosis with the other viruses which are prevalent at that particular season. And this is something that is unique to Omicron, and which we didn't actually find when we had the Delta surge last year. And in the Omicron period also, the reports from South Africa and also America was a bit more of a concern to us, because it not just had less lower respiratory tract problems, but at the same time it brought along with it the other pediatric problems of such as convulsions or seizures, which I'm sure a lot of us actually saw, not just in Sungai Buloh but all over the country. And the reports were there, and some of it was very atypical, and we were actually worried that we will actually have a surge of neurological cases during this time. And true enough, our prophecy was we estimated that it will come. We know that it will come eventually from South America to US, from South Africa to US, and then to us. And hence, when we had the Omicron wave again in February, again in Chinese New Year, I don't know why it happened. Anyway, we saw a lot of status epilepticus, breakthrough seizures in those who were diagnosed as epilepsy, and look at the amount of meningoencephalitis that actually came in, And this actually occupied most of the ICU beds that was available in our hospital. So the adults were actually not getting admitted because of the vaccinations, but we were occupying most of the ICU spaces because of this. And at the same time, look at the amount of simple febrile seizures that we had at that time. And a lot of them actually was admitted. And because of the nature of the COVID, most of them actually drained to hospital Sungai Buloh. Was also the same in March. because we know that the peak, takes about 6 to 8 weeks. Again, a lot of meningoencephalitis and also simple febrile seizures, something very unique to Omicron. And ICU admissions also at the same time, we had intracranial bleed and seizures, the status epilepticus and also meningoencephalitis. So enough work for these 2 months, in the ICU because of just neurological issues. At the same time, the symptoms were not just limited to neurology. We also had patients with a lot of croup. I'm sure the EDs, the pediatric wards was all inundated with patients with croup. You can actually hear the croup even from far. And the use of, palmicords, and dexamethasone went sky high in most hospitals. I think we had to borrow from other hospitals. And even the data from Seattle Children's Hospital actually already showed us that we were, had to plan for the onset of croup and also neurological issues. And as you can see, the amount of patients with COVID and croup actually was more significant in the Omicron period compared to the Delta period. And the other clinical manifestation of Omicron that we saw this year was also the onset of acute gastroenteritis symptoms, especially with vomiting and diarrhea. And again, something very unique to Omicron itself. And to the extent that actually some of them actually had pediatric surgical issues. And as you can see, the cases that was reported from overseas also show that, appendicitis was one of the manifestations of the pediatric Omicron infection in children, and also the pancreatitis and even interception. So there were a lot of, work for the pediatric surgeons. And we also saw this in our referrals to the pediatric surgical community. And this is just a diagram that shows the Omicron manifestations in children and also their laboratory markers. And as you can see, a lot of them point to abdominal issues and also elevated hyperinflammatory markers. So again, something very unique that we didn't see last year, although we were happy they were not as ill as the Delta variant, where they had a lot of pneumonia and some of them were ventilated. Again, this made us, occupied with a lot of other issues besides the upper airway and the lower airway. All right, some of the statistics, these are the recent statistics. As you can see, we are already on the downward trend at the endemic part of it. And our daily cases are in the thousands at the moment. And our positivity rate has come down from the peak of about 15 at the highest to about 4.9 or 4.9%. So it's almost around 4 to 5 now. And that means we are not out of it yet. And we have already forecast, even before the onset of Chinese New Year, what we are going to face. And we know that, the Omicron will reach our shores, and indeed it did on the 1st of February itself this year. There are deaths in children. I wouldn't, hide that, but most of it actually were in the older age group. All right, we can see here by the end of January, the use of beds in most hospitals was sky high, taking over the adult beds and also the wards. Same thing, and most of them were actually category 2. And sure enough, that we actually went into home quarantine in the early part of 2021. And we actually made more children stay at home this time because of the less ill nature of the Omicron wave. And the 2As were home quarantined, and the only 2Bs were admitted, or those with 2As but with underlying comorbidities. As you can see, although there are deaths in the pediatric age group, most of them were actually due to those with comorbids. But the ones that matter most actually were the geriatric age population, especially more than 60 years old. You can see that the amount of mortality among them is still very high, despite the fact that most of them have received at least 2 doses of the vaccines. And by this time, most of them have got their boosters already. So we have to be vigilant for the extremes of the ages, whether it's the young ones or the old ones, and be careful during this time. All right, case fatality rate is very low, even for the adult population, and even so for the pediatric population. Most of the deaths were actually those in the unvaccinated population during the Delta wave and so the Omicron wave. And the age group, like I said, is mainly in the geriatric population. And this study from America actually shows that the more mild to moderate nature of the Omicron cohort compared to the Delta cohort, and you can see there are less ED visits, less hospitalizations, less ICU admissions, and less ventilation in the Omicron group on the left here compared to the Delta group. But you must understand that the numbers, because of the high R0 of the Omicron, the numbers are staggeringly very high, close to about 30,000 even in a day. Remember the peak of it, and even 0.1 or 1% of that number is actually a very significant amount that will even sometimes overwhelm your public health service and your hospital beds. So even though it's milder, the 2Bs need to still be admitted, and although the rest needs to be home quarantined, it's still a staggering number that needs to be dealt with. All right, as you can see, the symptoms are less pronounced in lower respiratory tract for the Omicron compared to the Delta variant, and most of them circles around runny nose and sneezing, and less common of fever and lower respiratory tract issues. All right, so I've talked about it just now, and most of it focuses around the croup manifestations. The criteria for hospital admission, I'm sure you know from the annex series, all category 3 to 5, and those even less than 1 year old, or those with significant comorbidities. These are some of the comorbidities that everyone knows. We have a good amount of obese pediatric population in Malaysia, and especially so after the MCO. And of course, those with neurological issues, hematology issues, nephrology issues, and even cardiovascular issues are all part of the group of comorbid patients. I think those who have followed me before have heard me discuss about this group of patients before. The danger signs, even in Omicron, are related to many pediatric issues like dehydration, respiratory distress, seizures, as you've seen just now, meningoencephalitis, being lethargic and having a poorly conscious level, especially with CNS issues, and even inability to feed. And also plus or minus the dynamics of the family itself, because Omicron is so infectious, it's not just the child itself which will get, admitted, even the father and mother and grandparents will also be infected. And that is the crux of the pediatric COVID-19 issues, because the whole family gets infected and you have to deal with the whole family. Okay, the general care for children with COVID-19, I'm sure you know, we hardly use any antivirals, neither that we use as much biologics or monoclonal antibodies, but those which are admitted in this ICU care, especially in the Delta phase, we always co-manage with the pediatric intensivists very well. All right, this is the multi-system inflammatory syndrome that arose in the middle of 2020 when the authorities in US and Europe were finding a group of children and adolescents which has symptoms mimicking Kawasaki disease. Now, Kawasaki disease itself is unique to pediatric population itself. It's less than 5 years old, and there's a few criteria that you have to fulfill before being labeled as Kawasaki. And that is actually, because of the name, it's actually oriental in nature. And this hence is a more distinct entity, which is different from Kawasaki. But that's why it's called multi-system inflammatory syndrome of children. So it occurs about 2 to 6 weeks after the infection itself, and it has a wide variety of manifestations. And the most important one is that, which is the shock type, which actually comes in the collapse state and mimics dengue shock syndrome. The incidence is estimated in 1 in 3,000 COVID-19 infections, but this can actually be underreported because a lot of infections are, a lot of cases may not have been admitted to the ward, some of the mild ones especially. During the Delta phase, we had a lot, and I think we have quoted about 100+ mortality in the last report from the Delta phase. Again, this is how a patient with MIS looks like, and mimics the Kawasaki syndrome with eye changes, and some patients we found there is a BCG flare, something unique to our oriental population. Some of them has heart issues like myocarditis, and it is actually usually multi-organ involvement. One of the more authoritative criteria and consensus comes from American College of Rheumatology, and because a lot of drugs that is used to treat MISC actually comes from the realms of the pediatric rheumatology. So we have a few criteria, one from WHO, CDC, and also the Royal College. The ones that we use most of the time are ones from WHO. So it ranges from 0 to 19 years old, and it has to have a fever duration of more than 3 days. And some of the criteria comes from the Kawasaki criteria before, like rashes, conjunctivitis, and also multi-system involvement. Plus, the most important thing is that you need a laboratory marker of hyperinflammation, like raised CRP, procalcitonin, or ESR, and a lot of other drugs, a lot of other investigations which are done, especially the laboratory tests, as noted here, fibrinogen, D-dimer, and so on and so forth. So this plus the clinical criteria plus the history of COVID-19 infection, whether with RTK or PCR, clinches the diagnosis, and this patient should be admitted. If not, for monitoring, and the ill ones, of course, will have come to your EDs very soon. All right, you can get this from the American College of Rheumatology. I will not talk too much about it. The poor prognosis for these patients are those with comorbidities, which I talked to you just now. So as you can see, with one comorbidity, the ones in Iran actually has a 14% mortality. If you go up to 3, it's almost about 1/3 of that. So these are the ones that you should target your vaccination early if they are fulfilled, they are more than 5 years old. And these are the ones that you should monitor and have low threshold for admission. Long COVID insurance, you have been monitoring our category 3s to 5s. Some of them do have some hyperactive airways on follow-up, but mostly the 1s, 2s are usually quite mild, and most of the data at the moment do not show much morbidity in the long term. Okay, and the other things that I need to note is that if you vaccinate the mothers, then the babies actually get a lot of protection from their moms through the IgGs. And this actually is the key to actually protect our newborn. So as we go on to the next agenda, which is the vaccination in kids, just to remind everyone that, the mothers which was badly affected in the Delta wave can transmit the virus through intrauterine transmission, intrapartum itself, and so postpartum. And the sequelae can be vertical transmission or horizontal transmission. And there's entity in units known as MISN, multi-system syndrome in units, which is distinct and different from MIST. All right, the PICKIDS policy was to actually allow the kids to actually go back to school, parallel the success in the adolescent age group, which actually needed to take their SPM examination this year. And at the same time to control the COVID-19 infection and reduce the severity of it so that they will not spread to the elderly group in their household. Okay, this was the target, and we were actually targeting up to 60% of the 5 to 6 years old, and the older age group up to 80%, and those in hospitals were already targeted because they had comorbids. So our target was close to about 3.6 million actually. At the moment, it's actually a very slow progress at the moment as of actually just now. So it was about 33% which has received the 2 doses. And because the numbers did not actually differ much, I just kept the numbers from the last week's talk. But the adolescent is definitely a success story. Almost close to 100% of the adolescent population is vaccinated with at least 2 doses. Although we know that in the end, they will still get the Omicron transmission because of the immune escape in the Omicron virus, but they will not be hospitalized, and definitely they will not be admitted to ICU. So this allows the secondary schools to go on uninterrupted, and this is something of a success story. We need to work more on the 5 to 11 years old. And hence, I'd like to share with you some data from the Sinovac trials, and especially the phase 2 and 3 trials that was done in China, Chile. I will not talk too much about the Hong Kong one in the interest of time. Sinovac is not something new. It has already been in the market for close to about 2 decades. It is involved in influenza and mumps vaccine, and now varicella and COVID-19 vaccine. The data on the effectiveness of CoronaVac or Sinovac is already there in the top journals, and let's see what they did in Chile. All right. It's a very interesting study that they did there using two different dosages. One is the low dose 300 sievert unit, and the other one is the medium dose 600 sievert unit. And this was for 1 year from October last year and supposed to finish by today, this year. All right, so two groups of what do you call it, cohorts, and from 3 to 5 years old, 6 to 11, and adolescents 12 to 17 years old. For phase 1 in China, they had about 72 participants, and for the phase 2, it was a bit bigger, close to about 120 to 180 for the two groups of pediatric patients. And most of the adverse reactions in the phase 1 and phase 2 trial were just grade 1 and 2, which was mild side effects. And the main one was actually the injection site pain and some degree of fever. Percentage is about 4 to 5%, and more pain at the injection site. This is quite common even in our normal national immunization program vaccines also. And different dosages of coronavac were found. Remember, the 300 versus 600 was actually safe with no difference in terms of the adverse effects. Okay, and the humoral response in the 3 to 17 years old was quite good, and the geometric mean titer of the 3 microgram group, of course, was higher than the 1.5, which is the blue one compared to the green one. And this augurs well for the vaccine, which actually had a high bar set at 80%. And most of it reached more than that, 90% plus. Okay, right. And even in the phase 2 trial in heavy, actually showed good safety and also immune response in the two groups, and the same as the other sites. Now, the interesting thing is that when you give them a booster shot in the 3 to 17 years old, you can find that, this is day 28 after the booster shot, that the numbers of their antibody titers actually went up close to more than 30-fold, from 12.7 to almost 600 and 20 to 681. So that's an immense rise in the GMT of the antibody levels after the booster dose. Okay, so the point is that even minors, less than 12 years old, develop neutralizing antibodies for the two groups, and almost all of them have good antibody titers after the booster shot. So from the Chile side, they had the Delta variant almost the same time as we did in June. We activated, remember, the other hospitals in Klang Valley, Sedang Selayang and Ishtar around in July to help Semebulo. And they also had the Omicron cases just a bit early in December last year compared to February in Malaysia. So it sets the tide or the background for a very good trial in that country. Okay, so what they found that, overall, the protection effectiveness of the vaccine VE was about 65%. But look at the effect on protecting hospitalization and ICU admissions, 87%, 90%, and 86% in preventing mortality. So this is actually in real life data, real world studies, this is actually very effective itself. Although majority of them will actually get the infection, but as you know, it's very mild. Okay. And immune protection in children in Sinovac trial in Chile actually showed very good outcomes, even in the Delta wave and also in the Omicron wave. As you can see, the protection itself is actually quite high, and in practical sense, actually, basically what it means is that it works. All right. And they look at the time when Delta was a predominant strain in June last year, 2021. Again, the data was quite high, 75% vaccine effectiveness. Against hospitalization and admission was more than 90%. As for the Omicron period, when they look at the data again, although the protection against Omicron infection is only about 38%, but we know that happens, isn't it? Because Omicron has an immune escape, and that means it will infect almost everyone in the upper airway in the end anyway. But hospitalization and ICU still maintain more than 50%, and then that's actually quite something in practical in the real life. Okay, and the booster dose actually was given to those 16 years and above under the FONASA insurance system in Chile. And with that, actually, it actually protects the adolescents against more infections, more severe infections in the future. Although at the moment in Malaysia, we're only giving to those with comorbids and immunosuppressed and those more than 18 years old. All right, in Malaysia, we are still looking at our phase 3 trial data. We will have some interim analysis coming out soon. Sungai Buloh is one of the hospitals participating in the trial. We will share with you more data on it as the interim analysis is done. Okay, and post-marketing surveillance actually was done in most of the phase 1 and phase 2 centers. And so far, it was quite safe, I can tell you. So the results show that Sinovac actually prevents hospitalization and ICU admissions among the 3 to 17 years old. I'm not talk about the Hong Kong thing in the interest of time, and a lot of EUAs, emergency use authorizations was given in most of the countries that was using the Sinovac vaccine. All right, so the challenges is that at the moment we have a virus that is highly transmissible and has an immune escape. As you know, there are subvariants that is in the population now, the BA4 and BA5, and it's already there in South Africa. So we are just going to wait for it to have a small wave after this. The unvaccinated pediatric population with sub-immunity threshold protection will be one of the targets for this virus when it happens. And I'm sure, our population is a very close nucleus family with the father, mother, the child, and also the extended families of the grandfathers and so on. So it makes good, practical sense to actually vaccinate the children so that these things can actually be kept under control. All right. So now we are already in endemic phase, so everything is almost back to normal. We still have healthcare workers with breakthrough infections, and MIC cases already seen at the moment. These are the challenges we still have to face in the months ahead. So as you all know, endemic is just a term that we use, but as long as the virus mutates, then sometimes you have a small base in between. Zero COVID in Shanghai, Beijing, Hong Kong, and even Taiwan, is something of, everyone knows about it, how bad they are doing now, and whether it's something which is feasible or not, I think we can all decide on our own, isn't it? Huh? And I told you about the variants of concern. There's already probably, I think there's announcement already that is already found in Malaysia, and soon we might have a small wave coming. But whether it's as bad as the ones before, it's just a matter of time. But they have already had it in South Africa. All right, remember COVID-19 in children involves families. As a pediatrician and those of you who deal with children, I'm sure you know about this. You don't just treat the child itself. When you have something like COVID, you have also to treat the families itself. And in most hospitals, we manage the whole families, because most of them are actually in the milder stage. Yeah? So we manage the whole families in the hospital, and that's how most pediatric wards are filled up with anyway. Okay, so we know about this, so just a matter of time, it will come to all our shores soon. All right, so the take-home message is that most pediatric Omicron cases are mild. They're still home quarantine, but beware of the red flags I've told you just now. The paradigm shift, I'm sure you know, we have atypical symptoms now, so seizures, croup, and gastroenteritis issues, and even pediatric surgical issues. We need to ramp up the picket, it's it's not where it is, and that's why I think now with the end of the government involvement on the 31st of May, I think a lot of the frontliners, especially the general practitioners, will have a role to play in pushing forward the kids agenda so that more kids will be vaccinated, especially with the Sinovac vaccine. And at the same time, beware of MISC. Always ask yourself, if it's not MISC, is it dengue? Before you discharge the patient. Okay. At the same time, because I'm a neonatologist, we also manage most of the newborns in Klang Valley. So COVID-19 infections in newborns can be serious. And the thing that we can do about it is to make sure the the pregnant mother is actually vaccinated, because there's good transfer of immunoglobulins from the mother to the fetus, and that's the key to actually keeping the newborns from getting infection, at least through the vertical transmission. There's nothing much you can do about the horizontal vaccination until more children are vaccinated, especially those less than 5 years old. Breastfeeding is safe, and you'll be giving breast milk to all our babies, and it's something that we should actually continue, especially when there's circulatory IgA in the breast milk. And we always look at possibility of infant-mother bonding in any situation, especially now with high vaccination rates among the mothers itself. With that, I thank you for your attention.